السلام عليكم جميعا. اهلا وسهلا بالحضور. اهلا وسهلا وبنار جديد وبنار مهم نيونيتال هايبوجلايسيميا. واهلا وسهلا بالاستاذ دكتور يحيى Ethawi, consultant of neonatology and intensive care in Canada and the head of neonatal ICU Saudi German Hospital in Ajman in United Arab Emirates. طبعا ده يمكن ده تاني ويبنار نعمله مع دولة الامارات، وطبعا انا سعيد جدا بوجود الاستاذ دكتور يحيى معانا. انا كنت حضرت له قبل كده محاضرات في الكلينيكال ريسيرش، بصراحه كانت ممتازه، وطبعا ده شرف لينا ان يكون معانا الاستاذ دكتور يحيى، وشكرا ان هو لبى الدعوه. وشكرا على وقت حضرتك، واهلا وسهلا بحضرتك. انا هعرف نفسي سريعا للحضور. انا دكتور رامي شربيني، consultant of pediatric neonatology and pediatric clinical nutrition and associate alumni of Harvard Medical School. اهلا وسهلا بحضرتك دكتور يحيى، واهلا وسهلا بالساده الحضور. اهلا وسهلا بحضرتك، اتفضل.
Assalamu alaikum wa rahmatullah. Shukran, Dr. Rami, for the invitation, and very happy to be with Egypt. Been with many times with my Egyptian colleagues. Visited Egypt, love the place, love the people, love the country, the pyramids, the religion, the arts, everything. Egypt is really everything. I'm very happy here. And today I will be talking on a really important topic, which is the neonatal hypoglycemia, how to diagnose, when to manage, and other tips. So my objective is to talk about definitions and challenges, not changes, challenges of definition, a risk of hypoglycemia, symptom of hypoglycemia, general tips, and management. So to treat a problem or even to solve a problem, first you need to admit that there is a problem. And to admit a problem, you need to define it. So the problem with neonatal hypoglycemia is how to define it. So clinically significant, the definition would be clinically significant hypoglycemia that required intervention is difficult to define in numbers. And as you know, in medicine in general, we need number to treat. So above treat, below do not treat. So this is one of the first challenges. The level of glucose is very variable, and the response, the body response to various levels are also variables. And in addition to that, presence of these levels with or without treatment, what it is future effect is not defined, and we don't have data about it. So why these levels are variable? First, gestational age. So 23 different from 29, different from 40 weeks. Postnatal age, few hours after birth, is totally different from 24 hours from 7 days. Presence or absence other sources of energy, such as ketones or lactate. The circumstances that affect glucose metabolism in preterm baby. The uptake and utilization of glucose by the brain of a newborn baby is different. Now, the ideal definition of glucose concentration that need intervention will initiate or avoid significant morbidity, especially neurological sequelae. That is the definition of hypoglycemia. So it's a glucose level, serum or whole blood glucose level, that when we treat or initiate treatment, we avoid morbidity, especially neurological. The problem is the level and the duration of low sugar to provide or to lead to neurodevelopmental poor outcome is not defined. So here is an example of a study done by McNally, and it's a cohort study including large number size, and you can see they couldn't find or define neither the sugar level and the consequences, and they conclude that neonatal hypoglycemia was not associated with an adverse neurological outcome when treatment is provided to maintain glucose concentration at least 47 milligram per deciliter. So again, we don't know the level. So when we manage hypoglycemia, we need to do guidelines, to make guidelines for people to follow. The problem with guidelines need a definition and when to start treatment. So the main point of a guidelines is to define hypoglycemia and to define when we start treatment. The problem with these definitions, first, they are arbitrary, they are not real, and second, they are controversy. So you'll see different numbers with different guidelines. So what are the goals of guidelines? First goal is to reduce the harm from the hypoglycemia. And second is to reduce or treat the serious underlying disorder that cause hypoglycemia. But at the same time, the guidelines should minimize the over-treatment from low sugar level that is physiological. The favorite, or what we favor in the guidelines, is we favor the simplicity. So the guidelines should be simple so people can understand and follow. And it should be easy to use. It should emphasize the normal neonatal glucose level and normal age-related increase in glucose concentration in over first few days of life, and should emphasize the pathophysiological conditions that lead to clinical hypoglycemia. So when you review a guidelines of neonatal hypoglycemia, you should look at the glucose level. And you need to make sure the guideline consider glucose level or a threshold percentile range. It's very important to remember when you look at guidelines. Is it using a glucose level or using a threshold percentile? When you look at the glucose level, there are two types of measurement. First is the point of care measurement that use the whole blood, and usually it's at the bedside. And remember, it's 15% less than serum level. So when you review the guidelines, look, is it a glucose level or it's a threshold range? And then look, is the point of care, point of care glucose measurement, glucometer that use whole blood, or it is a serum level by a lab? Because the point of care glucose level is 15% less than the serum level. In addition, high hematocrit that's usually present in newborn babies affect the level. And remember, most of the guidelines depend on the plasma glucose level measured in the lab. So how we define hypoglycemia then? So it's a sugar level at which the glucose will interfere with metabolism. It's a sugar level that if we don't treat, there will be consequences. What is that exact level? We don't know. We start to know when there is metabolic decompensation, because when the glucose level goes down, the body, the organs that are servant to the brain, to the master, they need to change to provide constant glucose level to the brain. When they do that, they start to have decompensation. They start to have metabolic derangement, such as acidosis, such as lactosis, such as glucosuria, and so on. So whether you use a plasma lab level or whole blood point of care level or any method, the measurements of these levels either by millimole per liter, and these levels are, again, remember, these levels are arbitrary, and we don't know whether it's real or not, but it's a conservative number. So when the level is less than 1.7 millimole per liter or less than 30 milligram per deciliter, the brain starts to suffer, or what we call it glucopenia. When the level between 1.6 and 2.6, bolus might be needed to prevent possible brain sequelae, and it is about 47 to 60 in milligram per deciliter. When the level more than 3.3, we consider it normal, or at least there will be no derangement. However, to be comfortable, to grow, and to provide stable metabolism, the optimal level is 4 to 8 millimole per liter, or 72 to 144 milligram per deciliter, typing error. And more than that, there will be also derangement, or what we call it hyperglycemia. So these are how we define hypoglycemia or neonatal hypoglycemia. Now there are other divisions such as infant of diabetic mother, which is a baby born to a mother with diabetes, whether type 1, type 2, or gestational diabetes, with gestational on diet or on oral hypoglycemic or on insulin, all considered infant of diabetic mother. There are important emerging momentum definition called glucose gel, which is a kind of a dextrose, that is highly concentration, up to 40%, that we can administer to the baby through the mouth as a buccal administration. Most of these glucogel, the importance of these glucogel, they do not need a physician order and can be used by a nurse, and to prevent most of hypoglycemia and decrease the incidence of NICU admission because of hypoglycemia, and the dose is 0.5 ml per kg or 200 milligram per kg. Now there is something called the transition glucose level. As you know, when the baby inside, the placenta provides continuous supply of sugar at about 4 to 8 milligram per kg per minute of glucose. And therefore, the baby turns to growth and building body. They are not concerned, neither the organs nor the brain are concerned about glucose because of the constant infusion of this glucose. Now, after birth, the glucose supply becomes intermittent instead of continuous, and therefore the glucose level after birth falls. So in the first 2 hours after delivery, the maximum drop of glucose reaching a nadir of less than 40 or 2.0 millimole per liter. And it starts in the next 18 hours to increase until it stabilizes between 40 to 80 milligram per deciliter, or 2.5 to 4.4 millimole in the first 2 days of life. Now the rise will be more slowly level, not the first 48 hours. The rise in the first 24 hours after the 18 hours is a little bit fast, but after 2 days it becomes more slow. So after birth, what will happen? The plasma epinephrine will increase. The plasma glucagon will increase. And there will be fall in insulin levels. These lead to breakdown of the hepatic glycogen that is stored by the baby inside, when the baby inside the uterus, to make glucose. This process can be depleted within the first 8 to 12 hours. And therefore, the glucose production switched or shifted from glycogenolysis to gluconeogenesis. The gluconeogenesis uses lactate, glycerols, and amino acids. and this will be depleted soon. So if the glycogenolysis is depleted and the gluconeogenesis depleted, then the baby will be exposed to hypoglycemia. And therefore, to prevent this, you need to start feeding within the first 3 to 6 hours. The good neonatologist is to avoid intubation, give feeding. In addition, of course, to others, sedation and pain control. So these are 3 pillars of neonatology. Remember them always. Feeding, 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 and feeding. Aggressive feeding. Even 23 weeks, feeding has to start in the labor room before going to an ICU. So, very important to start feeding within 3 hours if you want to prevent hypoglycemia. And one of the pillars of good neonatology outcome is avoiding hypoglycemia and in addition to avoid hyponatremia, avoiding apnea. And people think that intubation and giving surfactant is the solutions, but it is not. Intubation and giving surfactant is not emergency. Controlling sugar is the emergency. Feeding is the emergency. Controlling temperature is emergency. Preventing apnea is the emergency. So you need to start feeding within 3 to 6 hours. Or to start TPN, or what we call a TPN starter, within 3 to 6 hours. Or at least give the baby dextrose to prevent loss of glucogenolysis and gluconeogenesis. And remember, about 10% of term normal newborn babies will not able to maintain a glucose level to be above 1.7. That's a term normal baby, remember. What about if it's infant of diabetic mother? What if the baby is premature? What if the baby has sepsis? What if the baby has RDS? What if the baby has PDA? What if the baby has IVH? So these are the baby will switch to fight the disease, but again, we expose him or her to hypoglycemia. So 10% of normal babies will not be able to maintain sugar using the glucogenolysis or gluconeogenesis. What about if they are sick? And remember, the effect of hypoglycemia is more than the effect of a congenital heart disease and way more than the effect of RDS. So what is the pathogenesis? How hypoglycemia develops? So we either have decreased production or we have increased utilization. So how we decrease production? Either we have inadequate supply or we have increased glucose utilization. So why we lose the production? We don't have store, or we don't have a proper glucogenolysis that we talked about, or gluconeogenesis. Why we utilize more? Because we have increased insulin, such as infant of diabetic mother, and they have other causes. So let's review some causes quickly. Inadequate glycogen store. When? Premature baby. Born before the 3rd trimester, and the deposition of glucose as a glycogen happens usually in the 3rd trimester. Infant who have growth restricted in utero. Why? Because they have reduced glycogen store. They are depleted easily to when they do extra, because they cannot shift from glycogenolysis to gluconeogenesis. They have more metabolic needs because of their diseases, and they have impaired glucose production because they don't have effective counter-regulatory hormones such as epinephrine and glucagon. We have impaired glucose production. Example, impaired error of metabolism, rare diseases, they are different, such as glycogen metabolism, but also we have other diseases of inborn metabolism, such as defect in amino acid or carbohydrate metabolism or FAO disorders. We have endocrine disorder that can fail the production of glucose, such as cortisol and growth hormone, endocrine problems. We have other causes of impaired glucose production, such as mother use of medications such as beta sympathomimetics, such as terbutaline or beta blockers, such as dexamethasone. Also, other causes of impaired glucose projection is hypothermia, and therefore, one of the important outcomes in an ICU is temperature on arrival to an ICU. Not the baby being intubated, not the baby being given surfactant. The most important point at arrival is glucose level on arrival, temperature on arrival, functional residual capacity. So one of the important is hypothermia. Also, if we have a premature baby has a premature liver, it can impair the glycogenolysis and gluconeogenesis. Increased glucose utilizations, either without hyperinsulinemia or with hyperinsulinemia. So without, example, in a baby with fetal growth restriction, or when the baby is sick and cannot use the ATP, or has anaerobic glycolysis because of decreased tissue perfusion, because of poor oxygenation, because of biochemical defect in metabolism. We have also polycythemia can cause the same problem. Heart failure, sepsis can cause increased glucose utilization. We have also increased utilization with hyperinsulinemia, such as infant of diabetic mother. Fetal growth restriction have both pathophysiology, with or without hyperglycemia. Pickwick-Woodman syndrome, asphyxia or stress. Giving glucose to the mother in intrapartum can also increase glucose utilization, because some of the glucose goes to the baby, stimulate the insulin, and then after the birth, the insulin sensitivity remain a little bit sensitive. Other hyperinsulinemia is persistent hyperinsulinemia of infancy due to genetic problem, or excessive use of exogenous insulin. There is neonatal condition that increase insulin, such as alloimmune hemolytic anemia of a newborn baby, or hemolytic diseases of newborn baby can increase sensitivity of insulin. So enough of the causes of hypoglycemia. Let's talk about symptoms. Symptoms are varied and non-specific, such as jitteriness or tremulousness, apathy, cyanosis, tachypnea, lethargy, lameness, difficulty in feeding, eye rolling, seizure, weak, high-pitched cry, sweating, pallor, hypothermia, cardiac failure, and arrest. And it's, yes, clear, it's a neonatal sepsis. So it's non-specific, and you need to rule out neonatal sepsis. Some of these symptoms are, we call it neurogenic, or related to autonomic nervous system. Some of them, they call it neuroglycopenic, due to low glucose of the brain. Example of neurogenic and autonomic symptoms, such as jitteriness, tremors, sweating, irritability, tachypnea, pallor. While neuroglycopenic, due to low glucose going to the brain, result in poor sucking, poor feeding, weak, high-pitched cry, change in level of consciousness, seizure, and hypotonia. And some of the symptoms are related just to being a newborn, such as apnea, bradycardia, cyanosis, and hypothermia. So what are the risks? If we need to read, we need to treat, and we need to define. We need to know risk where the hypoglycemia will develop. So any baby born less than 37 weeks, he or she is at risk of hypoglycemia. Any baby who is big, or she is big for her or his gestation, or small for gestation, or infant of diabetic mother. And when you have perinatal stress, such as birth asphyxia, or meconium aspiration, or erythroplastosis fetalis, or polycythemia. Some of the babies, they don't have hypoglycemia, but they have this, so the glucose are normal, but they develop symptom of hypoglycemia due to having CBT1 deficiency that prevent the utilization of the glucose despite the glucose level is normal. Some medication can cause hypoglycemia. Post-mature, after 42 weeks, is a risk of hypoglycemia. Any baby in the intensive care will be at risk of hypoglycemia. Use of beta-adrenergic and hypoglycemic agents can cause hypoglycemia. Some of familial condition, Pickwick-Woodman syndrome, Kapoki syndrome are associated with hypoglycemia. So, when you have a risk factor, screen your baby for hypoglycemia. The question now, we need to screen because we have a risk factor, when and how frequent we screen. So we screen any baby who's having a symptom consistent with hypoglycemia, but we have to rule out sepsis. And we have to screen any baby at risk, even without symptom. When we do the first screen, it should be after the feeding, not before the feeding. Because the first step of management of hypoglycemia is to feed. So probably it's better to feed and check the level if the treatment is feeding. So there is no point of checking glucose before you giving food. And therefore the food has to be given in a risk baby at the labor room. And the check should at risk baby or symptomatic within 1 hour after birth. Also, we need to check, even if not at risk baby, if the feeding delayed for the first 3 hours, because remember, both the glucogenolysis and gluconeogenesis will be impaired. But the second test, it should be pre-feeding. And it's usually 3 to 6 hours frequency in the first 24 to 48 hours. Most of symptomatic, at risk, or sick baby will have hypoglycemia, or if they present, they will present within the first 2 days of life. If the baby becomes stable, he's on full feed, still an ICU, or he's on TBN, then you need to test the sugar level at least once or twice weekly. Now, we know from the studies of at-risk babies, such as being preterm or large or small or infant of diabetic mother, that if you can look to the graph and you see the level become reaching 4 millimole per liter at age of about 12 hours of life. And therefore, if you have a hypoglycemia, you need to make sure that you are at risk, whether it's a symptom or it's a hypoglycemia. You need to make sure that you follow these babies in the first 24 hours of life. Now, how we test for hypoglycemia? So now we know the frequency, and we know who to screen. Now we need to know how we do the test. Now the test is being done by 2 methods. The point of care glucose meter that tests the whole blood glucose level, and it's a rapid test, and it's a bedside. The problem with this method is it has a large variation. And it's a screening, like any screening, there will be variation. So the method, when measure the glucose level being low, it might not be low, but it's a screening test. And because of the consequences of hypoglycemia is way more than hyperglycemia, then when we have low level by point of care glucometer, we should treat and send for true plasma level by the lab. Treatment should start immediately, not waiting the true level. Treatment not depend on the type of measurement. Remember that whole blood glucometer by point of care ultrasound is 15% below the lab level. And it becomes lower when the hemoglobin is high. Also, delaying processing the glucose, the blood sample, the plasma sample, will reduce the glucose by 6 milligram per deciliter per hour, or 0.3 millimole per liter per hour, due to red cell glycolysis. So you need to know when your lab measure from the sampling till processing, the delay of processing. You need to know that from your lab when you decide to treat. Now, there are other methods that is continuous measurement of glucose by glucometer or glucometry. Now, it's been started, but the problem, we don't know the true level that we can treat and interfere. But we know very well that the glucose level, like any vital or physical output, should have a variability. So fixed level is a problem, persistent low level is a problem, but going up and down within the range is the normal values. This is what we know. But exactly what is the level, we don't know. The other issue is it measures the interstitial blood glucose, not the blood glucose. So we don't have a comparison, but because when we measure the lab, we measure the blood, the plasma level. In this continuous monitoring, we measure the interstitial glucose in the tissue. So we don't know whether it's a comparable and what is the value until we have a validation result. At this moment, we cannot use glucose continuous monitoring. The other issues when you need to treat a problem, which is the hypoglycemia here, is when your parents refuse. So you do screening of at-risk baby, and you want to treat, and the parent refuses for various issues, for finance, for not believing, for patient-doctor gap, for some family conflict, whatever the reason of refusal. You need to make sure 2 points. First, it's not life-threatening, because if it's life-threatening, you have to overrule parent will. But if it's not life-threatening, then parents need to be educated and convinced, and if they are not, then their will should be respected. So, what is the diagnosis? How we diagnose hypoglycemia? Now you need to know the pathological neonatal hypoglycemia is not being defined as a number. All the number that you see, whether it's a true glucose level by point of care, whole blood or plasma, or it's a threshold as a percentile, is not being defined by number. When we say hypoglycemia, it's a level when we don't treat, there will be consequences, mainly neurological. However, a clinical level for neonatal hypoglycemia is important for the guidelines to initiate the therapy. So how we diagnose? We have two types of patients. We have symptomatic and we have asymptomatic at-risk baby. So these numbers are arbitrary and not true. So in symptomatic patient, less than 48 hours of life, a level of less than 2.8 millimole per liter, considered hypoglycemia. After 48 hours with symptoms, a level less than 3.3 is considered hypoglycemia. In asymptomatic baby who's less than 4 hours of life, 1.4 considered hypoglycemia. And here I'm using not a threshold, I'm using a plasma lab level. Between 4 and 24 hours and asymptomatic, a level of 1.9 millimole per liter considered hypoglycemia. Between 24 and 48 hours, a level of 2.8 is considered hypoglycemia. And after 48 hours, a level of less than 3.3 is considered hypoglycemia. When you have symptoms, you have to treat promptly with IV dextrose. Initiate as soon as whole blood glucometer test before true level plasma level. Do not wait for results. If the baby is asymptomatic, treat when there is risk factors and the level I showed you to prevent them from becoming symptomatic. The first intervention is oral feed, and therefore feed should be started as a routine in at-risk baby prior to the test. When you have low level, feed and monitor, and then depend on the level, whether it's within 48 hours of life or after 48 hours of life. And usually I use the 2.8 and 3.3 before and after. What are the differential diagnoses of hypoglycemia? Because the hypoglycemia is non-specific, the most important is to rule out sepsis. Also, neonatal abstinence syndrome from illicit drug or from drug used for psychiatric mothers, the symptoms are overlap with hypoglycemia. And these are the symptoms. So it's important to treat hypoglycemia in these babies and consider them at risk. Inborn error of metabolism can present with feature look like hypoglycemia despite there is no hypoglycemia. Hyponatremia can present like hypoglycemia. Encephalopathy, whether related, neonatal encephalopathy, whether it's related to hypoxic ischemic insult or other cause. Remember that the neuroglycopenia can happen with normal glucose level in GLUT transport protein deficiency. And these usually happen in certain ethnicities, such as Inuit people in up north. So when we treat, we should have a goal. Our goal to correct the glucose level in symptomatic patient to know whether the symptoms are related to the glucose level after the correction. When we have at risk, we treat to prevent the symptom. However, the goal needs to avoid unnecessary over-treatment or physiologically adaptation low level of the extrauterine life that is usually self-resolving without intervention. We need, when the goal of therapy is to identify the babies with certain problems or disorders or disease that cause hypoglycemia. And the most important of the treatment is to avoid the consequences of hypoglycemia. What are the challenges of therapy? The main challenge, the precise numerical glucose level and the duration of hypoglycemia, so the level and the duration, to cause consequences, we don't know. The timing of the measurement, we don't know exactly when we should measure. And the method of measurement are variable. When we treat, the goal is different whether we are symptomatic or asymptomatic. So what are the tips to treat hypoglycemia? If there is symptom, check immediately. Give treatment, and then go to the next step. So if you are at risk, but you are more than 35 weeks at birth, to prevent hypoglycemia, these are standard care. Skin to skin, because remember, hypothermia causes hypoglycemia. Feed immediately. Breast, right away, within 30 minutes of birth, or give 5 to 10 ml per kg of express milk if you are more than 35 weeks and you are at risk of hypoglycemia. Check the glucose level within 2 hours after the feed. And if you do that, and your level came to be more than 2.6, and you are more than 35 weeks, then you just need to continue feeding and monitor within 3 to 6 hours prior the feed. Next, check. And then you continue checking until you have 3 consecutive reading more than 2.6 millimole, and the baby is feeding. Or if you are infant of diabetic mother, or large for gestation, or you are at risk of CBT1 deficiency, continue reading for 3 consecutive normal and 12 hours of age. If you are small for gestation and your age is more than 35 but less than 37, you continue check for at least 36 hours, in addition to have 3 normal more than 2.6 millimole per liter readings. And you don't stop, even if you have a 3 consecutive normal, until your feeding is established. And you always need to check from the second reading prior the reading, which means a fasting glucose level. If you are asymptomatic and your glucose is 1.8 to 2.5, and you are still more than 35 weeks, because if you are less than 35 weeks, you have to be admitted to an ICU and an IV fluid should be started. So if you are 1.8 to 2.5, you already fed the baby and you check the level after the feeding, and level came to be 1.8 to 2.5, and you are more than 35 weeks, give glucogel level 0.5 glucogel glucose and 0.5 ml per kg, and feed the baby again and repeat the glucometers within 1 hour of your feed. And if it came again 1.8 to 2.5, then repeat glucogel a second dose, and then feed the baby and then check again. If the level more than 2 after the feed, so you get 1.8 to 2.5, you fed the baby, you give glucogel, before you give the second dose, your level become more than 2.6, then you need to follow what we did in last slide. If you repeat and the glucose level less than 2.6, the second after the repetition of second, then you need to send a true level and admit the baby to an ICU to start IV glucose. Now, if you feed the baby and the level is less than 1.8, you need to admit to an ICU and give bolus and start IV fluid. And the most important point is consult a neonatologist with experience in management of persistent hypoglycemia. What about if the baby is symptomatic, or the level, the first reading, is less than 1.8 regardless of the symptom? This is a very serious situation. Treatment has to be immediate, because it has a glucopenia, it affects the brain, and therefore you need to give the glucogel level immediately, even without feeding, admit to an ICU, repeat glucometers not within 1 hour, within 30 minutes, and give IV bolus of 2 ml per kg, and then you need to repeat glucometer within another 30 minutes. So within the 1 hour that we did before, you should have 2 readings. And you might need to start IV fluid. Usually I start at 80 ml in a term baby. Usually I start 60 in a preterm baby. I start 80 ml per kg per of D10. And if I need, I can increase them. And after you're in ICU and you have the level and you have the glucose infusion rate, you need to determine your next step based on the result and the situation. So, if the baby is more than 48 hours, but there is no known etiology for hypoglycemia, and the level not less than 1.8 is less than 2.6 before the feed, or it's less than 3.3 before of 2 readings, or there is one lab level less than 3.3, then you need to send for critical sample. So whatever the situation, your baby is more than 48 hours, and you don't have any idea, any clue why hypoglycemia happened, and the level less than 2.6 before the feed, or less than 3.3 after 2 feeds, or one lab level less than 0.3, you need to send critical sample, which means true blood sugar, mean serum beta hydroxybutyrate. If you don't have the serum beta hydroxybutyrate, you can use ketoacetic acid in the urine, but it's better to be serum hydroxybutyrate. You send cortisol level, insulin level, a growth hormone, blood gas, lactate level, and when you send blood gas, if you have metabolic acidosis with a deficit more than 10, then you need to consult a metabolic and or endocrine service. If your lactate is high, more than 4, you probably need another consultation, and consider central sample by central from a central vein to prevent hemolysis of sample and having false positive result. You need to consult either metabolic or endocrinology specialty, and you need to know how to treat acute and or chronic hypoglycemia. For the baby's confirmed endocrine or metabolic cause of hypoglycemia, you need to utilize appropriate checklist before you send baby home. And if the baby less than 35 weeks and he's ill and admitted to unit, all babies need to be checked by glucometer. The IV fluid should be adjusted according to the need of hypoglycemia, and subsequent management based on the results. And of infant, if the infant not metabolic and endocrine, but he or she is on TPN, glucose check should be continued at least once a day when the sugar level is stable. But if sugar is not labeled, you might need to do it every 6 to 8 hours. And again, you need to discontinue the check if the level more than 2.6 measured by feed after you stop the TPN. So how we manage hypoglycemia in babies more than 35 weeks? This is a very good algorithm. It's very tiny, but I can provide it to you. So I'm not going to go in this because I prepare this for people to, because it takes a long time to review this, but I can provide it to anybody who wants it. This is a schedule that we've talked about. It summarizes all what we talked about in one slide, but it's very small, tiny, and I don't want to take time, but it is the summary of what we talked about hypoglycemia in babies more than 35 weeks. So anybody want a copy of this? And I already made this for the Ministry of Health, so anybody wants, it would be in the guidelines of Ministry of Health. So this is a summary for the nurse on how to give the glucogel. So I'm not going to speak about it, but anybody again needs to know how to give the glucogel without having side effect and having a proper calculated dose and how to prepare it. This is a guidelines on how to prepare and give the glucogel, because I don't want to spend time on it, but the dose is 200 milligram or 0.2 gram per kg or 0.5 ml per kg, and it can be given twice by the nurse using a syringe plunger, and this shows to the nurse how to prepare it. This is the checklist of babies that we talked about when baby hypoglycemia with hyperinsulinemia when we go home, and this is the checklist that we need to check before we send baby home. Now I'm going to talk about, we talked about hypoglycemia in babies more than 35 weeks just by glucose, but sometimes we need medications. So these are the medications are diazoxide, octreotide, glucagon, hydrocortisone. So let's start with diazoxide. The dioxide can cause pulmonary hypertension, and therefore when we start diazoxide for hypoglycemia, and I'm going to tell you how to start and when to start diazoxide, we need at least to have a baseline echo to make sure that there is no pulmonary hypertension. The most babies will respond to a dose of 10 milligrams per kg per day. When we start diazoxide, we need to monitor a baby very closely. Now, it's not written in the textbook or even in the side effect, but I have monitored some babies on diazoxide oral. They develop bloody stool. Maybe I'm wrong. So remember, a baseline and periodic echo, even if it's done by a neonatologist as a bedside hard point of care, is okay. Initial dose, we start by 10 milligrams per kg per day. I give it 3 doses, so about 3 milligrams or 3.5, and then I gradually titrate the dose. Usually I increase the dose every 5 days, and usually the dose that control the glucose between 5 to 15 milligrams per kg per day, divided every 8 to 12 hours. You can use the diazoxide with the chlorothiazide because the diazoxide causes fluid retention. You always need to start the diazoxide when you are on IV dextrose, never on oral feed. The dosing usually individualized based on the patient and situation, and typically when the sugar level on dextrose more than 3.3 and on diazoxide, I start to wean the dextrose IV, and once I am off dextrose on full feed, I start to wean the diazoxide. Most of babies on diazoxide will get the response within 72 hours, and all of baby will get response after 5 days, and if there is no response after 5 days, usually they will not respond. Most of the babies to control need about 2 to 3 weeks of treatment. Those just need to be adjusted in renal impairment. It's a very prolonged half-life, so you need to be careful with renal failure and always monitor the sugar level. Octreotide used also in babies with persistent hyperinsulinemic hypoglycemia, and it's not the first line, it's the second line, and it has been associated with NAC, so be careful with babies having NAC. It also causes pulmonary hypertension, and hypoglycemia usually occur when there is congenital hyperinsulinemic hypoglycemia. Dosing are individualized according to the patient to keep the level more than 3.3, and again, it can be used as infusion, so therefore I'm not with it too much. I have lots of other side effects, so there are other alternatives if available, then it's better than octreotide. So we can use as intermittent subcutaneous and initiate at 5 milligrams per kg per day, divided doses, and then titrate the response, and we increase by 5 mic per kg every day, and usually the effective dose somewhere between 5 to 25 milligrams per kg per day in divided doses, or you can use it as a continuous infusion. The maximum allowed dose is 35 mic per kg per day. We can use it as continuous infusion, as 5 mic per kg per day as a continuous infusion. Other medication that we can use for hypoglycemia is for persistent hypoglycemia and for congenital hyperinsulinemia is the glucagon. The dose is 0.02 to 0.2 milligram per kg per day. Maximum dose is 1 milligram, and you may repeat the dose after 20 minutes. If you need more than 4 doses in 24 hours, then we go from intermittent IM or IV or subcutaneous to continuous infusion. There is wide variation in the dosing mentioned by manufacturer, and the continuous infusion is 0.5 to 1 milligram infused over 24 hours, depending on the weight and the gestation. And also you need to consider the level whether before or after 48 hours when you consider the glucagon infusion. The other medication that is used for hypoglycemia is hydrocortisone. And remember, hydrocortisone only for refractory hypoglycemia. And when your glucose infusion 12 to 15 milligram per kg per minute. So you're not allowed to use hydrocortisone for hypoglycemia if your sugar infusion is more than less than 12, and if you cannot, most of the time you cannot give a glucose more than 12 by a peripheral line, you need to consider a central line. The dose is 5 milligram per kg per day, divided every twice or 3 times a day, and the range is 1 to 2 milligram per kg per dose every 6 hours. So then how we approach hypoglycemia, glucose and medication? We check sugar level, and if the level somewhere between 4 to 8 millimole per liter, then you are infusing 5 milligram per kg per minute, then probably you can wean the baby and send baby home. If the level is less than 4 millimole or 72 hours, then you need to increase your infusion rate to between 8 to 9 milligram per kg per minute. And if the sugar is still less than 2.7 and you are less than 2 days, or less than 3.3 and you are more than 2 days, then you probably need to investigate the cause of hypoglycemia, sending critical sample. And if you are giving glucose infusion more than 9 milligram per kg per minute, and you need more than 12.5 dextrose, then you probably need to consider a central line. And if the concentration more than B5 to achieve a glucose level, then probably you need a glucagon boluses. If you need more than 4 doses of glucagon with using dextrose more than D25, then probably you need to go glucagon continuous infusion. If you reach glucagon continuous infusion, you need to consider diazoxide and or steroid. And if you start to use steroid or diazoxide, you need to consult, of course, endocrinologist, and then assess the response. And if the response becomes 4 to 8, you start to wean the dextrose. And if you are off the dextrose, you start to wean the medication. So how we treat infant of diabetic mother is a very challenging disease and very frequent, and they exposed to 3 main things: hypoglycemia, vomiting, and respiratory distress. First, you need to use glucogel, 200 milligram or 0.2 gram per dose, and you should never exceed by nurse more than 400 milligram, and is only used for babies more than 35 weeks. However, sometimes when I have very small babies, I cannot achieve an IV within 30 minutes, I might use it. And here a diagram or a table telling you how to manage a baby with infant of diabetic mother. So first, you need to consider the sugar level, less than 1.7 or 1.7 to 2.6 or 2.7 to 3.3 or more than 3.3, whether you are less than 2 days or more than 2 days, and you need to decide the frequency of checking. You need also to consider your total fluid intake, whether 80, 100, 120, 130, 150, depending on the gestational age, 1, 2, 3, 4 days. You need to know that your birth weight, your current weight, and your working weight. So you always use the maximum weight, and I'm always using a straight weight. So let's say if my birth weight is 1260, I use 1.3 kg. If my weight is 960, I use 1 kilo. If I am 1 kilo 55, I use 1.2. So that will be my working weight. And I always use the higher weight until the baby birth weight or the baby exceeds the birth weight or the working weight. Then I decide from all these, I decided my IV fluid and I decided my feeding. So what I do is, if I need until D12.5, I consider peripheral IV. If I need more than D12.5, I go to central line. I increase and decrease feeding by 10%, and depending on the level. So if the level is more than 3.3, I increase the feed by 10% and decrease IV fluid by 10%. If the level is between 2.7 and 3.3, I don't do any changes. If the level is less than 2.7, I increase the IV by 10% and decrease feed by 10%. If I reach full IV, I start to increase the concentration. And if the level is less than 1.7, I increase the concentration, the IV by 10%, and I give bolus. If the level below 2 point and I am on full IV, I cannot, and there is no feed, I increase the concentration. If I reach the 12.5, I go central. If I reach D25, I start to add medication. I feed the baby every 3-4 hours. Sometimes I feed over every 2 hours. And if the bolus, I go bolus. And when I say bolus, I mean feed over 20 minutes. But sometimes, because of big volume, the baby cannot tolerate. So I go on a longer duration of feed. Instead of 20 minutes, I go for 30 minutes, 45 minutes, 60 minutes, or a continuous feed. And I also do direct breastfeed. I give EPM or DPM. And I consider 20 kilocal time formula, but sometimes I go to 24 kilocal pre-term formula, and I sometimes might consider a high caloric formula, which is 30 kilocal or 1 kilocal per mil. I cannot use more than that. I sometimes consider other supplements such as MCT, methyl chain triglyceride, and protein. And with this, I end the session, and I will be happy to answer any question.
Thank you so much دكتور يحيى. شكرا دكتور يحيى على الشرح الجميل دوت، وشكرا على
I cannot hear you very well, Doctor.
على thank you so much. يعني حضرتك بصراحة يعني جمعت كل حاجة عن نيونيتال هايبوجلايسيميا، حتى يعني هيفيد all the gaps about نيونيتال هايبوجلايسيميا. شكرا لحضرتك وشكرا لذوقك وشكرا لوقتك. دلوقتي يا جماعة أنا هفتح الشات، بس على ما الشات ما يفتح اللي عايز يسأل الدكتور يحيى فيربلي دايركت يرفع ايده وانا هعمل له ان ميوت يتواصل مع الدكتور يحيى على طول، او اللي عايز يكتب على الشات يكتب وانا هقرا الدكتور يحيى. فاللي عايز يسأل الدكتور يحيى سؤال يرفع ايده حاليا بس لغايه ما الشات ما يرجع وانا هعمل له ان ميوت. طيب في دكتوره رحاب، استاذنك بس حضرتك عرفينا بنفسك وجهه العمل، ويعني حضرتك من مصر او من خارج مصر. شكرا ليكي. اتفضلي.
السلام عليكم. أنا دكتورة رحاب، أخصائية أطفال من العراق من الموصل.
أهلا وسهلا بيكي، نورتينا.
Dr. Yahya, I have 3 questions.
Go ahead, please.
First one, you always mention the phrase aggressive feeding. What do you mean by aggressive feeding? Is it the timing of feeding or the amount of milk given to the baby?
The timing. So aggressive feeding means when you are at labor room or when you are sick. So Dr. Rehab, always, even when you execute a person, يعني تعدمين واحد, they will give him a meal. So even if I am sick, I would be happier to die I'm full rather than I'm hungry. So when we say aggressive feeding mean early feeding, don't delay the feeding because of different excuses, 1. Second, don't stop feeding because your baby is sick, even if you're doing cardiac surgery. So you're only allowed to stop feeding. I do stop feeding when there are 2 conditions. First, that I have a bowel problem, spinal obstruction, or spinal ischemia. or neck, so bowel problem, or I'm sick. When I say I'm sick, I'm on 2 inotropes. So when I'm on 2 inotropes, I might reconsider the feeding. And when I reconsider, I will consider it after 6 hours. So feeding, feeding, and feeding, that's the mean of aggressive feeding. Now, it depends. You have to have a feeding protocol. And most of sick babies, if we're talking about the babies more than 35 weeks, then we don't need minimal enteral feed. We start feeding right away. So aggressive feeding means amount and timing. When we talk about babies less than 1,500 grams, less than 30 weeks, less than 27 weeks, we're talking about MEF. So mostly the baby needs TPN, and he or she will not get feed unless we are probably 3-4 days, because the MEF will be somewhere between 3 to 5 days. Yes, ma'am.
Okay, thank you. The second question is that, sorry, I couldn't attend the whole meeting because of electricity problems. Anyway, what is the time for the first glucose reading when there is a newborn with a risk for hypoglycemia within the first hour of life? What is the first time? What is the time for the first glucose?
As I told you, the baby can maintain the glucogenolysis by about 2 hours. So the feed, you should feed the baby immediately. So these are the conditions. First, feed the baby, and then check, and it should be within 2 hours of life. If the baby is at risk, if the baby is symptomatic, should be immediate.
Okay. My third question is that what do you mean by the following: birth weight, current weight, work weight?
Okay, so when the baby born, there will be a weight. Okay?
Yes.
So the working weight is the weight that you use it for calculation of medications, and then you need to use simple weight. So without fractions. So what I do is, when the baby born and I have a weight, so the working weight have 2 conditions. First is the maximum weight that you have, if the baby is not edematous, of course. That's one. Second, without fractions. So if the weight, let's say the birth weight is 1260, I will use a weight of 1.3, my working weight. And today my weight is 1.1, so baby lost weight. I will not go with 1.1. I will keep using the working weight of 1.3 until the baby goes back to birth weight. So when the current weight becomes 1.310, I start using working weight 1.4. When the weight becomes, let's say, 1430, I will start using working weight 1.1. So you have a working weight, you have a birth weight, and you have a current weight.
I didn't get it.
You didn't get it. So let's say...
احكيها بالعربي دكتور. احكيها بالعربي.
Let's give you an example. A baby birth weight is 1260. Is that okay?
Yes.
The working weight is 1.3.
Yes.
And today is day 5 of life. So the birth weight is 1260. The working weight is 1.3. And today is day 5 of life. And your today weight is 1100 grams. Because the baby lose weight and they go back to birth weight by day 7.
Yeah.
So if your unit is good unit, if you can achieve the birth weight by day 7, you're doing fantastic. If you achieve the birth weight by day 14, you're probably doing reasonably good. If you don't achieve the birth weight by day 21, then you have a bigger problem. So birth weight is the weight that you checked on the first, and usually it's the maximum weight because the baby starts losing weight. The working weight is the maximum weight, and without fraction. And the current weight is today weight. So if the birth weight is 1260, the working weight is 1.3. If the birth weight
you approximate
and today weight 1350, then the working weight will be 1.4.
You mean that you approximate?
I approximate and I use the maximum weight.
Okay. And you are going to use the work weight for measuring doses, for example?
For everything, for weight, for measurement, for all the measurements, yes. And I change the dosing every day with the change of weight. But usually so 1.3, I start 1.3. If the baby is 1.1, like 1.310, 1.350, 1.370, 1.380, it's all 1.4. So I won't change the measurement until, because I'm already ahead of the weight. I change the calculation every 4 to 5 days, because I always use ahead. So when the baby becomes 1.405, I am using 1.5. If the weight is 1.490, I use 1.5. So that helped me also to not change the dosing every day.
Concerning the IV fluid, are you going to calculate it according to the birth weight or the current weight also?
Working weight.
Working weight. Okay, thank you very much.
Working weight. Otherwise, you will start losing nutrition if you use the current weight. So I always use the current weight, the maximum weight with approximation, without fraction, as you said.
Okay, thanks a lot. Thank you very much.
You're most
شكرا
welcome.
دكتور يحيى. شكرا دكتور يحيى. شكرا دكتور يحيى. طب دكتور يحيى، انا عايز اسال سؤال دلوقتي. احد اسباب النيتال هايبوجلايسيميا السبسس. اوكي، لو النيوني ده دخل في سيفير سبسس، احد اسباب المانجمنت بيبقى اكستشينج ترانسفيوجن، والاكستشينج ترانسفيوجن برضه ممكن يعمل هايبوجلايسيميا. هيبقى ايه الحل في السيتويشن ده؟
You do exchange transfusion for sepsis?
Yes, in some cases, in severe sepsis,
I never use it. I never use it. So, yeah, you're right. If you have hypoglycemia and you want to do exchange transfusion, let's say for jaundice, not for sepsis, I don't use it for sepsis. I don't think there is evidence for that. You might use it. I have no experience with it. I don't expose too many sepsis because I'm very careful in management of sepsis, and I never use exchange transfusion in my life for sepsis. But let's say you're doing sepsis, whether for sepsis or using exchange transfusion for sepsis or for other problems, then you have to adjust your exchange transfusion in a way to maintain your glucose infusion rate. So you should never ever go below 5 milligram per kg per minute. So you have to calculate your exchange transfusion in a way to continue giving a baby 5 milligram per kg per minute. This is the lowest glucose infusion rate that is provided by the placenta. And when you are managing a baby, whether above or below 35, you should keep that infusion rate.
Yes, I mean, severe sepsis can lead to jaundice, and the severe jaundice can lead to exchange transfusion.
Yes, you can do exchange transfusion. That's why I said you are doing exchange transfusion and you have hypoglycemia. So it depends. What is your glucose concentration that you are using to keep your level? Because you need to keep your glucose level above 3.3, and your infusion rate should be normally between 4 to 8 millimole. When you have hypoglycemia, you have to go to 8 to 12. Once you start more than 12, you need to consider central line and consider medications. And then you got the exchange transfusion. So depend what is the glucose concentration, what is your infusion rate, and whether you are on medication or not. And during exchange transfusion, you need to keep your infusion rate at least 5 milligram per kg per minute. And if you develop hypoglycemia, you have a medication. So you can give boluses of glucagon, which is 1 milligram per kg, or continuous infusion of glucagon, or you are on diazoxite, and you can increase the concentration because you need to minimize the volume to give more room for your exchange transfusion. But the idea is should never go below 5 milligram per kg per minute of your glucose infusion rate. So you can increase the concentration, decrease the volume, and also you can use medications. But medication should never be used below infusion rate of 12 to 15 milligram per kg per minute. But if you want to drop it temporarily because you need a room for exchange transfusion, it should never below 5 milligram per kg per minute.
اوكي ثانك يو فيري ماتش دكتور يحيى. طيب لو في اي حد عايز يسال الدكتور يحيى برضه يرفع ايده، واستاذن الدكتوره رحاب لو هي مش هتسال تاني بس تنزل ايديها. لو في اي حد عايز يسال الشات اتفتح، يا اما حد يكتب على الشات او يرفع ايده وانا اعمل له اميوت ويتواصل مع الدكتور يحيى دايركت. في اي حد عايز يسال اي سؤال في النيتال هايبوغلايسيميا؟ طيب انا عايز اسال حضرتك سؤال بس هو مش في النيتال هايبوغلايسيميا. لو لو هو ولد لو نيونيت وبريست فيد اون كيوز يعني وفريكوينت وكويس وبيجيب يورين وستول وكده، ومع ذلك البيرث ويت بتاعه ما بيزيدش، يعني سوري الويت بتاعه ما بيزيدش. هل يعني وطبعا اتعمل له لاكتوز انتولرانس وكاوميك بروتين، يعني طبعا كاوميك بروتين مش كومن قوي في الايج دوت، اتعمل له لاكتوز انتولرانس، مفيش سكين فيكسيشن، مفيش دايريه، مفيش اي حاجه، بس نو جين ان ويت. ايه السبب؟ وهل الامبورن ايرور ممكن يكون سبب لده؟
Yeah, you're not gaining weight. You're either having increased utilization, so you have increased metabolic need, and one of it is inborn error of metabolism, or you have not enough calories. So you need to calculate how much you are giving breast, the amount of breast you are giving. Each 1 ml of breast gives you 0.68 kilocalories. So you need to calculate the volume by measuring the weight before and after the feed, and you need to calculate the calories. So your ideal weight, whatever the age of your baby, you should, to grow, you need 120 to 150 kilocal per kg per day. So first you need to calculate how much kilocalories you're getting from the breast milk. That's one. Second, if it's less than 120, you need to supplement the calories. And they have three options to increase the fat. The first, you give MCT, medium chain triglyceride. Each 5 ml give you 1 gram, and each 1 gram give you 9 kilocal. So usually I start by 1.5 ml every 6 hours of MCT. And I start to increase until I see the fat coming of the stool. When the fat coming from the stool, I back off and I continue on that. And that gives me the calories needed for the growth. If still the calories are not achieving 120, I start to add Infacare powder to the baby. So it's a concentrated milk. And then I give one, such as Infantrini, I think the name of that. So that contain 1 gram, contain 1 kilocal. So I give it like as a, one scoop in 30 mils. So each 1 ml contain 1 kilocalorie, and then I give 2 ml every 6 hours, and that will give you 4 kilocalories, and then I start to increase. If that's not enough, I add protein, pen protein. The pen protein is the same protein used by athletes to build weight. And I start to give 1 gram twice daily. In addition, I give multivitamins, and also I give vitamin D. And then I watch the weight. If I am on exclusive breastfeeding, if I am on other feed, if I am not on breastfeed or if breastfeeding is not enough, I add what we call it PDF or post-discharge formula. As you know that PAM formula contains 20 kilocal per scoop, or it's 0.68 kilocal per ml. The 22 contain 0.71 or 22 kilocal per scoop, so I can add PDF. It's not enough, I add Britam formula, which is 24 kilocal per scope or 0.8 kilocal per ml. And then I go to the hypercaloric formula, which is 1 kilocal per ml. Because it's very concentrated and the baby can vomit, I divide it to over all the time. And then I check the weight, and also I monitor the CBC and the renal function with electrolyte and then a monitor. One of the also important points that baby will not grow is the sodium is low. So some of these babies, they are small, they lose the sodium in the urine. So I monitor if the sodium is less than 140, they will never grow. So I start to give 3% oral sodium chloride each 1 ml contains 0.5 gram. So usually, if you keep the sodium more than 140, they start to grow. And I monitor that they usually need about 1.5 ml of 3% sodium chloride each 6 to 4 hours. They start to grow. Yes, sir.
اوكي ثانك يو سو ماتش. بس انا عايز بس اسال او يعني اسال عن حاجه في بعض النيونيت يعني مثلا الحاله اللي قلت حضرتك عليها ديت بياخدوا الفورمولا سواء اللي عشان to increase their weight and they got allergy from this formula وده بيخلي الحاله دي توليد اكتر. يعني هو الطفل النيونيت الوزن ما بيزيدش.
هو على breastfeeding you said, right?
No, yes, he's in breastfeeding.
Yeah, you
and
don't
after
give formula first. You give MCT. I
MCT.
don't go to the formula. As far as the baby is on breastfeeding and he's taking the breast, but he's not growing, then they have two problems. Either you have a calorie problem or you have a sodium problem. If you have a calorie problem, the best calorie provider is the fat, because each 1 gram of fat gives you 9 kilocalories. So if you give 2 grams of fat, you're getting 18. So if you give 4, then you're getting like very good amount of calories. So first thing, I add calories and I start to increase the MCT in the baby while he's breastfeeding, because it's very small volume and there is no allergy to it. And I start to increase it until I see the fat coming in the stool. Once I start to see the fat coming in the stool, I back off. And then I calculate how much the baby can get. If the baby can get 5 grams, then this is about 35 kilocalories, if I can give that. If that is not enough, I start to add other supplements, other proteins, such as Infacare powder or hypercaloric formula. So I take 1 scoop of this formula, add it to 30 ml of fluid, and then I give 2 ml every 4 or 6 hours. Each 1 ml gives you 1 kilocalorie. So I don't add formula to the milk to make the allergy, as far as the mother is on breast milk. And also I can give calories from pea protein. Each 1 gram of pea protein gives you 3.4 kilocalories. And then I check the sodium. Is the sodium normal in addition to vitamin D, and add also multivitamin? I don't go to the formula if the baby is on breastfeeding, unless the baby is not on formula. If the baby is on formula, then you have and you have allergy. You think they have allergy. So you can have lactose intolerance. So you have to either give lactose-free milk, or you give normal milk with lactase tablet or drop. And if the baby is not lactose, is a protein allergy, so you have 2 types. You have either protein allergy or you have cow milk allergy. And so you have 3 options. Either you use partially hydrolyzed or fully hydrolyzed or amino acid formula.
Yes, thank you so much دكتور. شكرا لحضرتك. شكرا ليك. دلوقتي يا جماعه هل في اي سؤال تاني دكتور يحيى اللي عايز يسال يرفع ايده او يكتب على الشات؟ في دكتور رمضان سلام لازم حضرتك بس حضرتك عرفنا برضه اسمك وجهه العمل والدوله اللي حضرتك من مصر او من بره مصر، واهلا بيك. اتفضل.
السلام عليكم.
عليكم السلام.
شكرا دكتور يحيى، الله يكرمك، جزاك الله خير. انا دكتور رمضان اخصائي اطفال في الدمام. سؤالي لو الله يكرمك، لو الطفل عنده 8 شهور وعنده دايابيتس، يعني جاي بدي كي اي ودايابيتك وهو بريست فيدنج، ازاي كالكوليت البريست فيدنج ليه وبيخش في اتاكس في هايبوجلايسيميا كتير؟
So he's on breastfeeding?
Yes.
Okay.
فمش قادرين نحسب له الكمية اللي بياخدها من البريست فيدنج.
So each 1 gram change. So you weigh the baby before, same glows, same before the breastfeed and after breastfeed. Each gram is 1 ml. So you weigh the baby before the feed and after the feed. And let's say if you get 25 grams of change, that means the baby, and then you do it with each feed 3-4 times, and then you will find the mean. So if you feed the baby 3-4 times, check the weight before and after each, and then you will have a mean. So you can have 3 weights, like say 30, 25, 20, and then you get the mean. That is your mean volume. And from that volume, if the baby premature, less than 21 days, then the EBM is a premature milk, which means the calories in that milk is 0.71 kilocal per milk. If the baby after 21 days, or the baby can, then the calories are 0.68 per milk. So let's say you are taking 25 ml per feed, and you're feeding 12 times, so you multiply 12, 25, 12, divided by the ideal weight, you get calories. You need a minimum, so you need, remember that, 90 kilocal per kg per day to maintain metabolism, 20 to 25 to fight diseases, and 20 to 30 to gain weight. So most of babies start to gain weight 120 to 150 kilocal per kg per day. If you are on exclusive breastfeeding and you don't need to change that, you don't want to change, you don't need to add milk, the best calorie provider is the fat, which is the MCT, and then Infacare powder as a hypercaloric formula, and because it's very concentrated and you give small amount, and you can add protein too, like plant protein, for example. So this is how to treat a baby who is not gaining weight on breastfeeding. Let's say you have a heart failure, or you have a premature baby that is gaining or catching the weight, or you have a metabolic decompensation due to inborn error of metabolism. I need to increase calories. Now, if you have a problem, last Dr. Rami said, it depends on the problem. You need to solve the problem. So I have very nice presentation. I don't know if somebody wants to invite. I can present feeding in special situations. So feeding in heart failure, feeding in catching the weight, post-discharge feeding, feeding in gastroenteritis, feeding in swallowing difficulties, feeding of infant of diabetic mother, and so on.
شكرا جزيلا. The best way ان نعالج الحاله ديت diabetic baby small age وعلى breast feeding، يعني الانسولين كيف ازاي نحسبه او نمشيه ازاي؟
So the baby is hyperglycemic and you want to start insulin?
Baby was when came he was 500 and acidotic.
Sorry, the baby is diabetic ketoacidosis.
Yes.
Right?
Yes.
And the age?
Age 8 months.
Age 8 months, and he's on breastfeeding or breast and eating?
Yes, on breastfeeding, yes.
Oh, okay. Well, diabetic ketoacidosis, you have to initiate the insulin infusion. Insulin infusion usually somewhere between 0.5 to 1 unit per kg per day. You have to increase the glucose intake and the caloric intake. You have to replenish the store, and then you have to calculate the 24 hours glucose. That is control the sugar, and you don't have urine in sugar, and pH is normalized and electrolyte normalized. Then you need to calculate the glucose and then divide the glucose over 4 hours, over like 4 doses or 2 doses, and then divide how much you give short and long acting. So that's like a completely different issues. Management of diabetic ketos need a whole talk, But when I talked about feeding, I talked about infant of diabetic mother. But feeding and eating and nutrition for babies of diabetic ketoacidosis, mostly you need milk and you need a standard pediatric diet. I don't know if you have it, called the NuSure. It contains a mix of food, contain all like a whole meal, and then it provide you exactly the calories that you want, because you can calculate the calorie from this NuSure whole meal standard pediatric diet, and then you switch to like a table diet. You need a dietitian with you. It's a little bit complicated topic, long time. I don't think I can answer like in a short question. It's a whole talk.
ثانكس، شكرا جزيلا دكتور يحيى.
شكرا جزيلا.
شكرا دكتور رمضان، شكرا دكتور يحيى، وان شاء الله يا ريت يا دكتور يحيى الفيدنج سبيشال سيتويشن يا ريت يبقى ده الويبينار القادم ان شاء الله يعني.
الله كريم ان شاء الله، انا بالخدمه. انا I will
شكرا.
also give a talk to Saudi Neonatal Society about swallowing and feeding problems. I think it will be in November, or in November. In October, in November, yes, in November. So anybody want to know, Dr. Abdurrahman al-Nimri is the head of the society, and they can get the link from there.
ان شاء الله، وان شاء الله، وشكرا لحضرتك وشكرا لوقت حضرتك، وثانك يو فور هافينج يوز اس. شكرا على المعلومات الجميله ديت، وشكرا للحضور اللي سالوا من جوه مصر او من خارج مصر. وان شاء الله دكتور يحيى يبقى في سيريز وبنظم مع حضرتك، طبعا حضرتك شرفتنا. وان شاء الله في الفيدنج سبيشال سيتويشن انا يعني هنسق مع حضرتك، شوف الميعاد المناسب امتى وننظمها ان شاء الله. وشكرا
ان شاء الله. اتشرف بيك يا اخي العزيز، الله يبارك فيك. شكرا
الله يخليك يا دكتور يحيى، نورتنا ونورت مصر ونورت الامارات كمان.
الله يبارك فيك، نور بيكم، الله يحفظكم ان شاء الله.
الله يخليك. شكرا
جزيلا. السلام عليكم.
السلام عليكم. شكرا للساده الحضور، وشكرا للاسئله والجميله دي، وشكرا للويبينار المثمر دوت، وان شاء الله نتقابل على خير في الويبينار القادمه باذن الله.
السلام عليكم.
وعليكم السلام ورحمه الله وبركاته. وبرده في لو حضراتكم تحبوا، في انا هنزل لينك برده واتس للي عايز يتواصل معانا، الويبينارز اللي هنعملها قبل كده، ولو حد عايز موضوع معين يبعت لي على الواتس، سواء حتى نيوناتولوجي بيدياتريك او حتى غير البيدياتريك، في اي حاجه في الميديسن، انا اهلا وسهلا ننسقها باذن الله. وبرده شرفونا على الجروب بتاعنا، جروب انترناشونال، ويا ريت الدكتور يحيى يشرفنا يبقى موجود فيه. ده جروب انترناشونال بنعمل فيها ناي ساينتفك ايفنت في العالم، مش في مصر بس، وبرضه عندنا البيج والقناه، وهنزل لكم اللينكات دلوقتي ان شاء الله.